This case is an example of peripheral arterial disease risk as a risk reduction. Okay, a patient with known peripheral arterial disease presents for routine follow-up. He has intermittent claudication but no wrist pain or ulcers. Which intervention provides the greatest long-term benefit? Immediate angioplasty, opioid analgesia, bed rest, compression therapy, smoking cessation, and cardiovascular risk modification. The correct answer is smoking cessation and cardiovascular risk modification. Why the most effective and long-term benefit strategy in peripheral arterial disease? It is the first line of treatment that should you start with, and it provides the greatest long-term benefit and the most effective strategy. Okay, in a case of peripheral arterial disease, is cardiovascular risk reduction. Cardiovascular risk reduction, particularly smoking cessation, and starting or controlling the diabetes. So smoking cessation and diabetes control, along with exercise to increase the functional capacity. Exercise. Okay. Why cardiovascular risk assessment is the most effective strategy? Cardiovascular risk reduction will significantly improve the symptoms, improve the claudication, the intermittent claudication associated with peripheral arterial disease, will reduce the pain on activity, and will reduce mortality on long term. So it has the greatest long-term benefit. Okay. Why the other options is incorrect? Angioplasty is reserved only for refractory cases. So we will start with cardiovascular risk reduction, and if the patient symptoms does not respond to treatment, does not resolve with cardiovascular risk reduction, then we should consider more investigations and further treatment as angioplasty with balloon dilatation of the narrowed vessel. So angioplasty is only done for refractory cases. We don't start with angioplasty in peripheral arterial disease. Opioids will mask the symptoms. So if the patient is using opioids, you won't distinguish between the peripheral arterial disease and the critical limb ischemia. It will mask the wrist pain associated with critical limb ischemia, so this is not good. Bed rest will worsen the functional capacity. As I mentioned, the patient should modify the cardiovascular risk factors. The patient should do exercise, and so exercise and activity is a part of the cardiovascular risk reduction, and bed rest will worsen the functional capacity. Compression therapy. I mentioned before that compression therapy is contraindicated in peripheral arterial disease, as compression therapy will decrease the blood flow to the limb. So it will worsen the disease, will worsen the blood flow to the limb. So let's talk about a peripheral arterial disease case which started the cardiovascular risk reduction. However, it was a refractory case. It doesn't respond to cardiovascular risk reduction. So it was considered a refractory case. That's why we decided to perform more investigations as Here, this patient, we decided to perform more investigations for and more treatment as angioplasty to widen the narrowed vessel. As you can see here, the vessel here is obstructed. Okay. So this case, a 59-year-old male presented with left arm pain on activity. Left arm pain on activity. Whenever you see limb pain on activity, this is intermittent claudication because it's on activity. So it's intermittent claudication associated with peripheral arterial disease. This patient started the risk factor modification. However, the symptoms does not respond to the cardiovascular risk modification. So here, this is angiogram. 2 spot images from an angiogram at the level of the aortic arch. Both images show the left shoulder joint in the abducted position. So the left shoulder joint here is in abducted. It's not adducted. Okay? It's elevated. Okay? Abducted position. So these are 2 angiogram images at the level of the aortic arch. This is the aortic arch. Okay, and these are the aortic arch vessel. The aortic arch branches. Okay, this is the brachiocephalic, left common carotid, left subclavian. This is the innominate artery. We gave the right common carotid artery and the right subclavian artery. The left hand image shows contrast filling of the aortic arch with filling of the brachiocephalic trunk and the left common carotid artery. There is filling of the proximal subclavian artery. Okay, so he's talking about the left image. The left image showing filling of the aortic arch, filling of the brachiocephalic trunk, filling of the right common carotid artery and the right subclavian artery, and also filling of the left common carotid artery, and there is filling of the proximal left subclavian artery. Proximal left subclavian artery. But then there is a complete occlusion with no filling beyond it. After filling of the proximal left subclavian artery, there is no filling beyond it due to complete occlusion. Okay, so there is a complete occlusion of the left subclavian artery. The right hand image shows a slightly delayed film with contrast seen in the left vertebral artery. Here, this is a delayed film with contrast filling the left vertebral artery. As you know, the vertebral artery is a branch of the subclavian artery. So when the subclavian artery is occluded, it will steal blood via the vertebral artery. It will steal blood by a retrograde flow through the vertebral artery. Okay, so a retrograde flow through the vertebral artery will give blood to the subclavian artery. So as you can see here, the left subclavian artery is opacified with contrast here by stealing blood from the left by a retrograde flow through the left vertebral artery. So the right image shows a slightly delayed film with contrast seen in the left vertebral artery, best seen at the level of the C3-4, providing filling of the distal left subclavian artery. Filling of the left distal subclavian artery by retrograde flow through the left vertebral artery, best seen here. The diagnosis here is subclavian steal syndrome. This is a condition that is usually acquired and caused by atherosclerotic disease. Atherosclerotic disease. So this is a kind of peripheral arterial disease caused by atherosclerotic disease, stenosis of the subclavian artery resulting in stealing of blood to the arm via retrograde flow of the ipsilateral vertebral artery. This is the management here. Diagnosis can also be made by ultrasound with Doppler flow. The ultrasound can identify the reversal of Doppler flow in the vertebral artery. Reversal of Doppler flow in the vertebral artery. Further management, CT scan, non-contrast CT scan can detect the calcified atherosclerotic plaque in the proximal left subclavian artery. So CT scan, non-contrast enhanced CT scan can detect the calcified atherosclerotic plaque that cause narrowing in the proximal left subclavian artery. Okay. Contrast enhanced CT scan arterial phase can detect the degree of stenosis of the proximal subclavian artery. Okay. Management here is surgical referral. For treatment, you can say vascular or interventional radiology referral, vascular surgery referral. The treatment here will be balloon dilatation. Okay. Angioplasty with balloon dilatation plus or minus stent insertion. So the treatment here is by angioplasty with balloon dilatation. And if the balloon angioplasty fails to widen the lumen, widen the obstructed lumen, Then stent insertion is the next step to insert a stent, okay, to regain the lumen. Then, if the stent insertion failed, surgical bypass. Surgical bypass, okay, surgical bypass, common carotid to subclavian artery.